evening, everyone, and welcome. I'm just taking a look here. We've got 31 participants with us. I'm going to give it another minute and see who'll join before we dive in and start with our main event tonight. Okay. Well, again, welcome. My name is Arvind Janab. I'm the Medical Director of Naturopathic Medicine at the Samueli.institute and the Director of Naturopathic Medicine Residency. I want to welcome you all to our Integrative Insider event tonight. Thank you for joining us for this free community lecture. Our main clinic, if you don't already know, has moved. So we moved from Costa Mesa to campus at UCI. Our brand new space was designed to optimize delivery of integrative health. And if you haven't seen it, please come visit. Wonderful space and lots of great activities and new programming to support patients. We also offer integrative services at UCI, health sites in Newport Beach, near Fashion Island, Pacific Breast and Oncology, Hematology at Pacific Medical Plaza, in Costa Mesa, Yorba Linda, and also Laguna Hills. So we're happy to see our services are expanding and growing, and that patients are excited to see us to support them in their healthcare. So again, I'm really privileged to be here with you and to introduce Dr. Jacob Hwang, who's our speaker tonight. Before we start, though, I'd like to go through some housekeeping items. We're recording this session, and after this session, we'll be posting this webinar on our YouTube channel. So if you want to go and revisit it, or if you have friends and family that want to view it, please feel free to go there and forward it to them. In this webinar, everyone will be muted and videos will be off. Please utilize the Q&A feature at the bottom of your screen for any questions or to communicate with us during this session. After the presentation, I'll moderate a Q&A session, so please send your questions, and that's always an interesting part of this program, is to see what questions you have and for Dr. Hwang to answer those questions. All right, so on to our main event for tonight's session. Dr. Hwang will be presenting on muscle mass. The onset of muscle mass begins after the age 30 with an approximate decline of 3 to 8% per decade. This rate of muscle loss decline is faster after the age of 60. And what Dr. Jacob Hwang will be exploring with us is various factors that may be contributing to age-related muscle loss, and he will discuss different preventative strategies. Hope you find it interesting and relevant. To introduce the speaker, Dr. Jacob Hwang is a naturopathic doctor. We're proud to have him here. He was a resident at the Samueli.institute who completed residency and has joined us as a full-time provider. He is a naturopathic doctor full-time with us. His expertise are in cardiometabolic disease, kidney disease, urologic conditions, and men's health. He also sees a variety of other health conditions as an integrative health specialist. In addition to clinical practice, Dr. Hwang actively contributes to the development of various educational initiatives and leads the didactic curriculum for our naturopathic residency program at the Institute. He earned his doctorate in naturopathic medicine from Bastyr University in Washington and completed 3 years of postgraduate residency at Bastyr Clinic, as well as the Susan Samueli Integrative Health Institute. During his free time, Dr. Hwang enjoys spending time with his family, traveling, as well as outdoor activities. Please join me in welcoming Dr. Jacob Hwang to Integrative Insider Live. And thank you again for being with us. Dr. Hwang?
Thank you, Dr. Now, for the wonderful introduction. Let me go ahead and share my screen for the PowerPoint. Okay. All right. So good evening, everyone. My name is Dr. Hwang. Thank you, everyone, for sharing me a part of the evening today to participate in this webinar called Muscle Matters, Understanding and Combating Age-Related Muscle Loss in Men. Although the topic will be kind of geared towards men, there will be some relevant information that could be applied to both men and women for this topic. So let's begin. Before I go further, I have no disclosures or conflict of interest. So our learning objectives for tonight will define what age-related muscle loss is and why it occurs. We'll recognize health risk associated with muscle loss. We'll look into some contributing factors to age-related muscle loss. And lastly, we'll talk about different strategies to preserve muscle and ultimately prevent muscle loss. So let's take a look at a definition. What is muscle loss? So the muscle loss that I'm going to talk about today is going to be defined as sarcopenia. However, in the presentation, I will synonymously use sarcopenia and age-related muscle loss as the same definition. But sarcopenia can be defined as an involuntary loss of muscle mass, strength, and function that occurs with age. Okay, the key word here is involuntary. So sarcopenia, we know that it is a fundamental cause, and it does contribute to a lot of disability in older people. As you can imagine, when you start to lose muscle mass, you lose muscle strength, and that can ultimately increase someone's proprioception, their balance, which is why we do see increased risk of falls. With that, an increased vulnerability to injuries, and ultimately, when someone has these injuries, it can definitely increase the risk of functional dependence later on in life. So it can be a pretty problematic comorbidity for a lot of people in the older generation. So when does muscle mass begin? As we kind of stated, muscle mass loss is not an issue just for older individuals. We actually know that muscle mass actually starts to decrease about after age 30. And the rate of muscle mass decline happens around 3 to 8% for every 10 years. So really the muscle mass loss starts early on, really kind of the first third of your life. However, the rate of decline as muscle mass does go higher after age 60, so it does kind of accelerate. Sometimes when we lose muscle mass, we also see an accumulation of fat mass. And that's why we have changes in body composition. As people get older, they may have noticed that they have lost muscle mass but gained more fat mass. So ultimately, we do see these kind of correlations. Now, why does this happen? Is there a cause for sarcopenia, which is this involuntary loss of muscle? Well, the cause is not really clearly understood, but there's likely multiple things that are happening at once that are really contributing. So as we age, we know that muscle cells decrease, which leads to decreased muscle function and overall muscle unit. We also see neuromuscular alterations. Neuromuscular alterations are the connections between your nerves and muscles. Obviously, for us to use our muscles, our nerves are communicating, right? So that type of connection does get altered with age. Lastly, we do see changes in satellite cell numbers and recruitments. What is a satellite cell? Well, a satellite cell is, you can think of it as like a muscle stem cell. So obviously, when you have different numbers, in this case, less satellite cell, there's less of these muscle stem cells to actually repair muscles and also to rebuild muscle as well. Other things that have been observed is that mitochondrial DNA damage has been reported in relation with muscle loss. A lot of times we see this with other types of mitochondrial dysfunction, which does seem to be a common denominator in a lot of other chronic diseases. So just want to kind of point out some of the things I just mentioned. So that cell in the yellow box there is a satellite cell. So I just want to kind of show and kind of illustrate that these satellite cells are like stem cells. They will eventually turn into functional muscle cells, which becomes muscle fibers and overall your muscle tissue. So with age, we do know that the satellite cell numbers do decrease, which means our body's ability to repair, build muscle, it does get lower. This next picture I'm showing, don't get distracted by the other things out there, but my whole point is to show that as we age, we do see more and more mitochondrial dysfunction. Mitochondrial dysfunction happens with age, with oxidative stress. With muscle loss, we do see damaged DNA. So as you can see, the line there on the left, starts off with green, but towards it, with more age, we do see more dysfunctional mitochondria. And that's very important because in mitochondria, which you can see here is located in the muscle tissue, obviously mitochondria is what we call an organelle. And an organelle, you can think of it as in a cell. An organelle is like an organ in a cell. So this mitochondria in these cells is actually the energy producing factory of the cell. So your cells need mitochondria to create energy. With energy, it's able to do its function. Now, I do want to point out that there's some organs that do have a higher density of mitochondria, and these are going to be your heart, brain, kidneys, and muscles. Obviously, when you look at those organs, they have a lot of different functions, and they're constantly very busy and using up a lot of energy. So as you can see here, mitochondrial dysfunction with age, obviously, well, we do see that with muscle mass loss. So let's talk about some health risks associated with muscle loss. So we just talked about what is age-related muscle loss, what are some things that causes it. We know that there's changes in different cells, changes in mitochondria. So, why does that matter, right? Like, why should we care about, the loss of muscle besides cosmetic or aesthetic appearance? Well, there are some health risks involved. Insulin resistance is a major one. So typically, when you consume a food and that gets broken down to blood sugar, your skeletal muscle, which is the muscle that you're using, that you have volunteer control over, actually is responsible for 80% of that glucose uptake from overconsumption for food. What that means is that when you eat food and that gets broken down to blood sugar, your muscle is actually responsible for using up 80% of that. So you can imagine that as you age and lose muscle, you no longer have the ability to really absorb all that glucose, right? And that's why sometimes, when you think about insulin resistance, it actually starts at the area of the muscle. When we look at the risk of diabetes as people age, it goes up, right? Now, partially that might be explained to the fact that we also lose muscle mass as we age, which might lead to insulin resistance. So as you can see here, muscle has a direct role with insulin resistance, which is a driving mechanism for diabetes development. And keep in mind, people could have this process of insulin resistance for a very, very long period of time before diabetes actually develop. So it's a slow kind of progressive process, but we do see insulin resistance as a mechanism for a lot of other chronic diseases. So really muscles play an important part here. Like insulin resistance, obesity, we know the insulin resistance can also cause obesity. So one thing, I want to kind of introduce is this term called sarcopenic obesity. Sarcopenic is referring to sarcopenia. And this is when people have obesity due to increased fat mass and decreased muscle mass. So obviously in this situation, this actually worsens the disease process and worsens metabolic health. So again, having muscle mass that increases the risk of obesity and insulin resistance, which are ultimately influencing each other. And then really the third trifecta to that is cardiovascular disease. Insulin resistance, obesity, cardiovascular disease, these are all kind of shared mechanisms and things that are associated with muscle mass loss, right? We tend to think of like the larger individual with more fat mass as like the highest risk for these things, but keep in mind, even if they have fat mass, they likely also have muscle loss. So a lot of these mechanisms I just kind of point out and discuss, that's probably why these things are really correlated as health risk associated with muscle loss. Another important thing I don't want to miss is with loss of muscle does increase the risk of low bone density problems such as osteopenia and osteoporosis. So muscles and bones have a mechanical relationship, right? Muscles are attached to bones, and when muscles move, they actually put pressure and tug on the bone. What that does, that stimulation actually helps maintain and stimulate bone growth. So that's why with low muscle mass, we do see increased risks of these things happening. Another thing I want to point out is also that it's likely a hormonal decline that may play a role in both kind of low bone mineral density and muscle loss. We know that estrogen in postmenopausal women, that hormone tends to decrease, which leads to bone loss. But keep in mind, estrogen is also made from androgens, such as testosterone, and testosterone is involved with helping maintain muscle mass. So I'm just introducing this concept early on, but we'll talk more about that in upcoming webinar soon. So to summarize, really, we know that age-related muscle loss has some health risks. These are insulin resistance, obesity, cardiovascular disease, low bone density, and osteopenia and osteoporosis. So my whole point here is that muscles are not just things that for cosmetic or aesthetic purposes, but they're actually very protective against main disease processes. Maintaining muscle mass, it will be important for really preventing or worsening chronic diseases. So let's talk about contributing factors to sarcopenia. So we just talked about the definitions of what causes it. We talked about some health risks. So let's talk about the actual factors that kind of drive or may explain this type of muscle mass loss. So I just talked about hormonal changes. So one thing I just want to just kind of repeat myself is that really the main hormone I want to kind of introduce is testosterone. This is a primary anabolic steroid. Anabolic just means, to build something from units, right? So we know testosterone, one of its many actions is that it increases muscle protein synthesis, muscle mass, and muscle strength. And we also know that the aging male can gradually experience lower testosterone levels over time. In fact, men who are over 65, over 60% of them actually have low testosterone levels. Now, low testosterone, you may have heard this, and sometimes there's different terms that are oftentimes have the same kind of criteria. These are terms such as hypogonadism, andropause, symptomatic androgen deficiency of the aging male, or ADAM. So those are all kind of conditions that are really focusing on low testosterone, which has other consequences. But in this setting, I'm talking about its effects on the loss of muscle. In addition to low testosterone, there's other hormones I want to point out, and these are growth hormone and DHEA, or dehydroepiandrosterone. So like testosterone, both growth hormone and DHEA has also been shown to decrease gradually with age. Now, there are some clinical studies that have tried to replace these hormones in men. So with growth hormone replacement, what they found was that it did increase muscle mass, not muscle strength. However, that interpretation, increased muscle mass, was to be taken in caution. And the reason for that is when people take growth hormone replacement, it actually increases water retention. So when they measure mass, they may be actually measuring water, not true muscle mass. Okay, so at this time, they don't recommend growth hormone replacement due to other potential side effects as water retention and worsening of instances actually. DHEA, they've also tried supplementing that in men, but oral supplementation of DHEA did not show any changes in lean body mass. So testosterone, growth hormone, and DHEA, we know that they do all decline with age, but out of the kind of totality of different clinical trials, really testosterone replacement seems to be the only one that can consistently increase muscle synthesis, muscle mass, and muscle strength. However, testosterone replacement therapy is not recommended solely to replete or attenuate muscle loss, but it can be considered if it does meet the diagnostic criteria for hypogonadism. So if someone has hypogonadism and they're on testosterone replacement therapy, oftentimes they'll get or notice a side benefit of a better ability to build or maintain muscle mass. So the next thing we'll talk about that will contribute to sarcopenia is physical activity. Now, it is difficult with kind of in the greater research if a sedentary lifestyle contributes to sarcopenia. Obviously, that is very hard to measure and to monitor. But what we do know is that short-term muscle inactivity, as for example, people who are in bed, hospitalized, or not able to move, we know that that type of condition does reduce muscle mass and strength. And we also know that when people do acute exercise, that also increases muscle protein. So likely with that type of rationale, we can probably assume that physical activity is probably beneficial for preventing sarcopenia or muscle mass loss. Oftentimes, we start to wonder, well, does the type of physical activity matter? So studies have looked at that. Aerobic exercise, which is typically exercise that's going to increase your heart rate, has been shown to improve mitochondrial density and sensitivity. That's important, right? We just talked about that with muscle mass loss, we do see mitochondrial DNA being damaged, leading to mitochondrial dysfunction. So that's important. Aerobic exercise can also have a really positive effect on really your nerve and muscle connection, known as the neuromuscular connection. So it doesn't really build muscle mass, but when we start to increase the intensity with aerobic exercise, that has been shown to increase muscle protein synthesis, okay? Which means we're creating more muscle protein, but not obvious muscle hypertrophy. Muscle hypertrophy is just, you can think of it as, if aerobic exercise likely will increase the number of muscle cells, but not necessarily the cells themselves are not going to be very large. So when people have bigger muscles, they don't necessarily have more muscle cells. They can actually have increased muscle cells, but those muscle cells are just bigger. Okay. Now, people can still get hypertrophy or enlarged muscle with intensive aerobic exercises, but obviously nowhere near towards different types of exercise, such as weight training. However, these muscles, even if they don't appear as big, they don't necessarily lack strength and power. For example, if you look at gymnasts, they tend to have more of a thinner frame, but their muscles are very, very strong and capable of holding much more than just their body weight. The other type of exercise I want to talk about is resistance exercise. So resistance exercise is obviously, things that involve with weight training, using the principle of resistance and overload, meaning giving more weight to your muscles to kind of overpower. And one particular type of resistance exercise is known as progressive resistance exercise, has been shown to induce muscle hypertrophy and muscle strength. So not necessarily increase muscle cells, but increase the size of the muscle cells to lead to hypertrophy, okay? However, this is not, we can't really apply this to everyone because some people have certain comorbidities or they're not able to do some of these, type of exercises. So really an example of like a progressive resistance exercise is something like, ultimately what it means is that you're just progressively increasing your strength. So, one way to do this is, people may increase their weight by 2 to 10% per rep, or they will eventually increase the number of reps. Or sometimes they'll switch up the intensity or reduce the rest time between your exercises. Or sometimes, progressive could be slowly increase your time under tension. maybe you're holding a dumbbell, but instead of pulling up to your biceps, you're holding it out longer for maybe 5 to 10 seconds more each time, or ultimately just overall increasing your workout in general. Those are kind of different types of progressive resistance exercise training. So both aerobic and resistance exercise do play a part to help counteract sarcopenia and metabolic alteration of the aging muscle. The good news is that the aging muscle can still respond to anabolic stimuli. So using both types of exercises can be very helpful to not only increase muscle cells, but also increase the size of the muscle cells and strength as well. The last thing we'll talk about as a contributing factor is nutrition. We do see kind of aging is associated with kind of progressive reduction in food intake, meaning people just tend to eat less as they age. Oftentimes we're worried about increased risk of malnutrition. We also tend to see kind of decreased dietary protein intake when people age. Now, the decreased dietary protein intake, that may be due to the fact that as people get older, they may be kind of dealing with more chronic diseases, such as cardiovascular disease or diabetes. And oftentimes when people are dealing with that, they tend to shift their dietary pattern to less protein and kind of more vegetables or plant-based diets, right? So that's why we do kind of see that decrease. It's almost like an unintentional consequence that happens when people start changing their diet to focus on other chronic diseases. So really the question is, do older individuals require more dietary protein? And that is still a debate to this day. We have one health organization that will say, older individuals will need 0.8 grams of protein per kilogram body weight. But, in the topics of maintaining muscle mass, that number is actually higher. They suggest that maybe these people need 1 gram per kilogram of body weight per day of protein. So the debate continues, and I think it's really more of an individual recommendation based off, their chronic diseases, overall health status, and et cetera. And next thing I want to kind of look at is that are there any nutritional deficiencies that are associated with muscle loss? So let's look at some vitamins. The things that have been mostly studied are going to be vitamin D, vitamin C, vitamin B6 and 12. Really, as people have tried to correct vitamin D deficiency to see if that changes muscle mass. However, the results are very inconsistent and mixed. So it's really hard to say that if it does do that solely. Some studies that have used vitamin C showed improved muscle performance, but not necessarily increased muscle mass. And people who actually have a B6 or B12 deficiency, fixing that actually helps with muscle repair and the neuromuscular symptoms. So, none of these vitamins actually do anything directly for it, but obviously they kind of help with overall muscle function if they're deficient. Let's look at some minerals. Calcium. So they looked at daily calcium intake and sarcopenia prevention. However, the studies have not been really consistent to show if that's, a major contributing factor. Selenium, some studies have showed that, muscle performance and muscle mass has been increased with dietary selenium intake. But keep in mind, when you say dietary selenium, it means foods that contain selenium. But those foods also contain other things besides selenium, like protein, right? A lot of your selenium-rich foods are going to have protein. That picture in that presentation is a Brazil nut. Those are going to be a major source of selenium. But in addition to Brazil nuts, we get selenium from fish, meat, cheese, sunflower seeds, baked beans, mushrooms, oatmeal, spinach, milk, yogurt, cashews. So some of the foods I mentioned, are going to have other things in it. So likely, I can't say if it's really selenium or the other things in selenium that are helping with maintaining and building muscle mass. The last mineral is magnesium, and some studies have showed that using magnesium has been able to show improved muscle performance and help retain muscle mass. Let's look at some nutrition. So when they have looked at like commercial nutritional supplements or even using high protein diets, they have often been very unsuccessful for increasing muscle mass, muscle strength, and muscle protein synthesis. And the reason for that is when they start to kind of break down these proteins and their amino acid makeup, right? So amino acids, you can think of it as like the basic unit, and these amino acids will come together to make peptides, and these peptides will come together to make a protein. You can think of it as kind of these things broken down. So when you look at the content of these high protein diets, we can kind of separate them as essential and non-essential amino acids. What they have found was that essential amino acids can help promote muscle protein synthesis, while non-essential amino acids did not appear to have any effect on muscle synthesis. Essential amino acids are going to be these 9 amino acids that mammals cannot synthesize or create therefore we need it from our diet. That's what they call essential. The non-essential amino acids are amino acids that our body can produce by its own, which means we don't need it from our diet. So obviously, one study looked at when they used non-essential amino acids, it didn't help with muscle mass growth, but then when they combine that with essential and non-essential, then we start to see some sort of effect there. However, there's no data that's done like a prolonged supplementation of essential amino acids in the elderly to see if that actually is safe or does help maintain muscle protein synthesis. So that question still remains to be answered. So obviously with that, we will likely need more long-term randomized clinical trials to really to have a clear assessment. Okay, so lastly, let's talk about some strategies and approaches. So obviously with sarcopenia, the decline of muscle mass starts early, after the age of 30. So with that, I think prevention is huge here. Prevention is worth more than an ounce of cure. So really actively trying to avoid these other comorbidities such as cardiovascular disease, diabetes, obesity are going to be crucial. Because when you have those conditions are what we call secondary aging. Okay, primary aging is when you age as time goes on. Secondary aging is when your aging process is actually accelerated because of these conditions. So as I mentioned earlier, the cardiovascular disease, diabetes, obesity all have very shared mechanisms. And that's why having that in the cell counts can worsen muscle loss. So obviously preventing those things are going to be crucial for combating age-related muscle loss. Second thing I want you to consider is hormonal health. If you suspect that you have symptoms that are significant due to hormone decline, then maybe consider an evaluation. Get your hormones levels tested to see if that's a contributing factor. Nutrition, maintaining adequate dietary protein intake based off your current physical activity output will be important. Focusing on essential amino acids is going to be important as well, and obviously correcting for any deficiencies. Physical activity using both aerobic and resistance exercise are going to be very important to prevent and improve muscle health. And likely maintaining some sort of physical activity over time will be very useful to help preventing sarcopenia. So my key takeaways from this webinar is that, first and foremost, is that muscle loss due to aging is multifactorial. It's not by a single cause. We know that maintaining muscle mass and strength is protective against many chronic disease processes, and it can protect against cardiometabolic disease and low bone mineral density. Out of all the hormonal decline we see here, low testosterone seems to be the most consistent and significant contributing factor. For exercise, both resistance and aerobic exercise can help increase muscle mass and strength, and obviously maintaining adequate exercise can prevent that. And lastly, instead of a high protein diet, essential amino acids can help build muscles. So obviously, maybe considering that in addition to regular dietary protein intake can be very useful. So just want to thank everyone for your attention. So I think we'll move on to the next part of this integrative insider.
Thank you, Dr. Hwang. That was very informative. I appreciate that. And just thinking as a provider working with so many patients who are looking for ways to increase muscle mass, and I think some of the information coming out around longevity science that increasing muscle mass and preserving muscle mass supports longevity and healthy aging. I'm already thinking of so many ideas and so many ways to maybe approach it with patients based on just some of the things that you described. I want to move on and invite the audience to submit questions. I've got a few that I'm going to start to just read out for you, Dr. Hwang, to answer. Mm-hmm. And yes, the audience, please forward your questions in the Q&A, and I'll be happy to start looking at those and sharing with you. So Dr. Hwang, the first question is around testosterone therapy in patients who are on anti-androgen therapy due to prostate cancer. So could you comment on that?
Yes, absolutely. So with prostate cancer, oftentimes they'll use therapies to reduce the level of androgens. And that's why men often have side effects related to low testosterone. So I think the data is changing. And obviously, this is a question that's going to be between your urologist and oncologist. But I think even you said urology, they have done testosterone replacement therapy as a clinical trial on people with prostate cancer. And I think that study showed that people on testosterone replacement therapy had a delayed recurrence compared to the cohort that had prostate cancer without testosterone therapy. Again, what we should conclude is that it's still preliminary, but the evidence around testosterone replacement therapy and prostate cancer, whether or not it can be used safely, is changing at this time. So my understanding of urologic research is that, depending on urologist, that could be, considered a conversation. Again, that will ultimately depend on the grade of the prostate cancer and the staging of it. But I do think there might be some urologists that are maybe open-minded to see, hey, can we find a middle ground here to work with you?
All right, thank you. So another question from one of our participants. Are there any studies that would imply limits in which too much physical activity can contribute to muscle loss after the age of 60?
That's a great question. I haven't looked at that question in particular, but there was another study that looked at excessive exercise actually increased the aging process. So, I can't quote you a study, but with that principle in mind, they did find people who were doing more exercise and ate more calories had an increased catabolic rate, which actually increased their aging process. So I don't know of a study off the top of my head, but I think by principle that makes sense. I do think there's probably a nice balance there where excess can actually worsen the aging process.
And this may be a question of type of exercise. So just to add, too much aerobic exercise without enough resistance or weights can lead to muscle mass. I think that's something that we've seen with patients.
Yeah, absolutely. I do think, when we look at these marathon runners, right, they lose a lot of muscle mass and they tend to be more thin as well.
Yeah. All right, next question is to do with, so it's a compliment, great talk. Any data about difference in loss of muscle mass by race or ethnicity?
Ooh, I don't know if that answer, if I can quote you a study, but that's something that I'll probably look into. Yeah, I don't know if there's, I will maybe imagine that might be some differences, right? Because we do see ethnic variation with other things, with other disease processes. For example, like, the threshold for mailbox syndrome in Southeast Asians is lower than your European descent individuals. So there are physical parameters for other diseases that are different. So I would imagine that it might be the case for kind of muscle mass breakdown as well.
Okay. Thank you. Any risks associated with hormone therapy for men over 50?
Any risk for hormone risk? I'm assuming testosterone replacement therapy for men over 50. So whenever a man considers testosterone replacement therapy, he needs to be evaluated and confirm that he has hypogonadism. Hypogonadism is going to be when your total testosterone level is less than 300, and this test needs to be repeated twice. Now, the other thing to consider is if someone has a family history of prostate, breast, or ovarian cancer, you might want to double think that. And if someone has, potential history of a past cardiovascular event or thrombotic event, that is also something that you do want to consider as well before beginning that. So the risk associated with that is whenever you begin on testosterone, you're always worried about, stuff like, will it worsen my BPH or benign prostatic hyperplasia that can enlarge your prostate. Another thing you want to be worried is that when you start to do testosterone or when you increase it too much, your hematocrit can also increase, making your blood thicker, which can also increase the risk of clots. So that's why it's very important to meet with a healthcare professional to discuss this risk, get tested, and see if it's an appropriate thing to consider.
Thank you. And I think your talk also reminded us that it's not always about hormones.
Yes.
So it's also important to make sure that the muscle mass or decline in muscle mass is actually related to hormones before getting treatment with hormones.
Correct.
All right, another question. I think it's a follow-up to the exercise question. How much is too little and how much is too much, and whether or not something as simple as long walks can help?
Yeah, absolutely. I think for maintaining muscle mass, obviously number one is what can the patient do? Like, what are you able to do? Because obviously sustainability is going to do a lot better than things that are going to be short term. So it's really finding what that individual enjoys doing and kind of increasing that. Roughly speaking, having some sort of aerobic regimen combined with some sort of resistance training, maybe twice weekly, is probably a safe recommendation to try. But obviously, if someone's not enjoying those type of exercises, they're not going to be doing it. And I think it's really the long-term picture. If you're able to sustain this into your lifestyle, that's where it becomes really effective. So really, I think it depends on the individual.
Thank you. I think this next question is really important and something that we use at the clinic. And it has to do with monitoring muscle mass. So the question is around how we monitor muscle mass or track changes over time.
Yeah. So so obviously with monitoring muscle mass, our clinic uses a machine called InBody, and it's what we call a bioimpedance machine, and it's able to kind of calculate your body composition, and it breaks it down to muscle mass and also fat mass. And it's using this by using different electrical currents that are run through based off the water content in your body. So there's no perfect tool because obviously we can't biopsy people's muscle, but the InBody is a non-invasive way to kind of track changes over time if someone's trying to build muscle mass.
Thank you. So we have time for a few more questions. So just looking at some of the questions coming in. So the question is around high blood pressure, whether resistance exercise can be a risk in patients with high blood pressure.
I don't think so. I imagine this question is being framed because when people really push weights, I think about that person maybe kind of overexerting and maybe visibly seeing their veins pop up, right? For example. No, I don't think so, because we talked about insulin resistance and how muscles are a huge component of it, and insulin resistance also drives the development of hypertension. So maintaining muscle mass will actually counter active against that. So for me, I think resistance exercise is going to be important and protective. So I don't think it will necessarily increase the risk of hypertension. And if someone notices blood pressure spikes with exercise, it's always important to go see a cardiologist or your doctor to make sure nothing else is going on, because there can be something else underlying that is causing that type of side effect.
Wonderful, thank you. And so for the last question from our participants, any effect of nitric oxide on muscle mass?
Yeah, so nitric oxide is produced in our bodies. Sometimes we're able to get this from foods or sometimes from supplementation. But nitric oxide, really downstream, what it does, it improves blood flow. It causes vasodilation, which means it opens up the arteries. And with that, when there's more blood flow to muscles, then the muscles are able to have more nutrients, and also the muscles can deposit waste products to the blood. So obviously, yeah, I think optimizing blood flow to your muscles will indirectly help with maintaining muscle mass and improving strength.
Great. Thank you, Dr. Hwang. Since we have a couple of minutes, I have a question for you.
Yes.
And my question is, if a patient was to come to you and is experiencing muscle mass or looking to increase muscle mass, what is the steps that you would take to determine what might be contributing to their decline in muscle mass?
Yeah. So I guess my first thing is really, listen to the patient and figure out their whole health history. So my first job would be to evaluate the past medical history. What are some current problems that they're dealing with? And then examine their diet and lifestyle, examine their physical activity, look at those parameters. And if those things are not optimal, my next question is like, why are they not optimal? So I'll kind of dive deep into that. And then likely I will order some, diagnostic tests to evaluate that. Sometimes, if that's the primary goal, then maybe we'll get a baseline InBody scan to get a basic body composition, and then followed by an evaluation that looks at metabolic risk factors, depending on their age and other symptoms. I may or may not check hormones, but obviously if they're of age and have other symptoms such as low libido or other things in that kind of arena, then I might look at testosterone to see if that's something that they're also struggling with.
Great, thank you. Well, I think that concludes our event. I want to thank everyone first I want to thank Dr. Hwang for this really informative talk. Thank you for being with us tonight and sharing this information. And I also want to thank everyone for joining us for our Integrative Insider Live community lecture. Upon ending the webinar, a pop-up window will have a valuable survey on this evening's event. So please take a look and take a minute if you have the time to answer some questions and give us some feedback. And I'll improve our community offerings through some feedback from you. We'll also be emailing key takeaways from this talk through email that is provided at the registration. So keep an eye out for that. Our next Integrative Insider Live is scheduled for September with SSIHI's concierge provider, Dr. Marcela Dominguez. So keep an eye out for that invitation. There's more information that will be sent out through our Integrative Insider monthly emails and posted on our website on the events page. So please visit that site for any upcoming events and keep an eye out for emails from us for upcoming events as well. Thank you again, and we look forward to seeing you again next time. Thank you, everyone.